So thank you, Dr. Parul, for the kind introduction and the inclusion. So the topic for today is basically the presentation and management of meibomian gland disease. Excuse me. So by definition, it is a chronic diffuse abnormality of the meibomian glands. So it's commonly characterized by terminal duct obstruction and or changes in the glandular secretion. And this may result in the alteration of the tear film, then symptoms of eye irritation, clinically apparent inflammation, and ocular surface disease. So if you see the prevalence and frequency, it varies, but the numbers are quite high, as you see by the highlighted box here. If you see the Indian data, all the studies have pre-pandemic, it is ranging from 10.3 to 47.7% of the sampled population. So it is the meibomian gland dysfunction is characterized into two states, low delivery and high delivery. The high delivery part are the rare cases we hardly see in the Indian population. Acne rosacea is there, but it's difficult to appreciate in the whitish complexion of the Indian subcontinent. The most common part which we see is the one in the middle, the obstructive part, in which because of any inflammatory disorders, either it is primary or secondary, the orifices of the glands are obstructed, leading to alteration of the tear film and subsequent tear film changes. So you can see the etiology, either it is non-cicatricial or cicatricial. So the cicatrizing disease is more severe. It is either due to some skin disorder, atopy. Basically, there is the scarring of the submucosa and the posterior migration of the orifices. In the long term, the management of the cicatrizing variant is extremely difficult. So these are the few of the manifestations of the meibom. You can see the pouting of the glands. Here you can see on this photograph the toothpaste-like secretions. Here you can see the dilatation of the orifices with the telangiectasia surrounding them. Here you can see the posterior migration of the orifices in the cicatrizing form of MGD. There is one disorder which not many of us are familiar with. It is called as meibomian keratoconjunctivities. So the name implies that both the cornea and the conjunctiva are affected. So starting from anterior, there is anterior blepharitis, which is seen characterized by crusting and lash loss. In the posterior blepharitis, you see oil stagnation in 100% of the cases. There can be orifice abnormalities in 50% of the cases, and a foam kind of a thing if you see carefully at high magnification on the lid margin. Also, there is reduced tear secretion. The Shermer is usually less than 10, and 100% of the cases have a reduced tear breakup time. SPKs are also widely seen. You can pick them up nicely on the rose Bengal staining, but it is quite irritating to the ocular surface. So fluorescein or lissamine can also suffice. The ocular surface as a whole is inflamed with bulbar injection. So most of these patients you will see at the lateral angles, near the canthus, they'll keep on telling you that this redness somehow doesn't go down. So beware of this entity called as meibomian keratoconjunctivitis. And the clinical associations can be seborrhea or seborrheic dermatitis. So also ask them if they have any skin disorders as per se. Another variant along with the MGD is something called as plus disease. So plus denotes something extra in over and above the MGD. And you need specific different treatment for each of these plus conditions. So it can be a exaggerated inflammatory ocular surface disease, for which on the right hand side you see you need soft steroids. If there is mucosal keratinization, you may end up needing a BCL or a scleral contact lens. If there is a flick-10, again you need steroids. If there is a trichiasis, basically in the cicatrizing form, either you need a epilation or a cryotherapy in the long term. Chalazion will be discussed sequent in the last talk. If there is anterior blepharitis, you need a combination of topical antibiotics or antibiotic steroids. If Demodex is associated along with the blepharitis and you see cylindrical dandruff and slit lamp, you have to prescribe tea tree oil scrubs. So any of these is called as a plus disease. So there is a way and an order of performing the tests in diagnosing MGD. You start with the questionnaires. you see with and without a slit lamp, then you see the tear breakup time, then you go to the staining, which is followed by looking at the morphology, the margin of the lids, then you express the secretions of the meibomian glands, give a 10 minutes break, and the last test is the most invasive generally, that is the Shermer test. So you ignore this photograph, you just focus on the table which I'm showing now. That is basically the summary of the MGD staging used to guide treatment. So you have stage 1, 2, 3, 4, and also you have the plus disease, which I have shown earlier, whose treatment is a bit different. So in stage 1, the MGD grade is basically very minimal alterations in the expressibility and the secretion quality of the oil. And symptoms are usually not present. The staining is also not present. So it is very mild. As you move on till stage 4, the secretion quality, the expressibility worsens, like the toothpaste secretion I showed earlier. The symptoms are also very marked, and the staining is also marked. Mostly it is, apart from the diffuse stain, it is more concentrated in the center. So now you have the severity levels, level 0, 1, 2, 3, 4, and then 5. So that was the staging. This is the severity grading. So here you have level 0, there are no symptoms. Level 5, it is symptomatic all the time. It is very disabling. The patient is extremely disturbed. If you are in the habit of using the OSDI, at level 5, the score is almost from between 33 to 100. The tear breakup time at level 5, it is instant. As soon as you instill the dye, there is a breakup spot seen. Osmolarity is generally not done, not advised, because it is a highly difficult test to perform, in the sense that the results are not easily interpreted. It's very variable. And the staining, again, severe staining at level 5. If you see the MGD grade also at the last stage, it is extremely cicatrizing and very poor quality of the secretion. And the treatment varies as per the severity, as we all know. So if you come to the stage 1 in detail, so no symptoms, very minimal change in the secretions, no stain. So just inform the patient about the nature of the disease, some lifestyle modifications, and also consider basic eyelid hygiene, and maybe including warm compresses at home. At stage 2, very minimal to mild symptoms, very mild changes in the secretion, and diffuse grade staining is between 0 to 7. So apart from the lifestyle changes shown above, improve the ambient humidity, change the lifestyle if they're especially heavily dependent on the computer, and increase the dietary omega-3 fatty acid, eyelid hygiene, warm compress. And if there is a plus disease, you have to go for artificial lubricants, maybe topical antibiotics as well. We currently don't have any drops which contain the lipids. At the stage progresses, you have to keep on adding the drugs, maybe oral tetracyclines, anti-inflammatory, including pulse steroids. These will be subsequently shown in the next talks. These are the heating pads and the other devices, including LipiFlow. One controversy is whether you should give omega-3 fatty acids or not. One review which came out last year has shown a moderate daily dose may be beneficial for MGD. But the 2018 article from the DREAM project has shown no benefit of omega-3 fatty acid supplementation. Currently, in my practice, I do prescribe a small dose of oral omega-3 fatty acid in the more severe disorder. Also, like the photographs that Dr. Parul showed in the end, so the DREAM project again did not get any association of the gland morphology with the symptoms and signs of dry eye disease. So we still do not know what the different manifestations of the morphology mean in terms of the treatment and the prognostication. Thank you so much.